This is a topic very near and dear to my heart, and I hope you'll take the comments I make about this today to heart in light of some of the comments that Dr. Gonzalez made earlier about assessing a sick child where you don't know what's going on. Because I think most often when somebody presents with acute adrenal insufficiency, not in a setting where you've already figured out that they have this disorder, things get missed. This disease is commonly overlooked and people die from adrenal insufficiency. The reason I wanted to bring this to your attention again, I think I've done this before in this meeting, is that the signs and symptoms of adrenal insufficiency are commonly misinterpreted as something else. Unrecognized and untreated adrenal insufficiency kills children. They die. And it's very sad because it's very preventable. And I really want everybody in this room to become very vigilant to this disorder, this family of disorders, almost paranoid, because this is so treatable, so imminently treatable. It's like giving glucose to somebody who's hypoglycemic, but if you don't realize what's going on, you're in trouble. So just a brief review, the hypothalamic pituitary axis, we got hypothalamus that secretes corticotropin releasing factor. That stimulates the release of ACTH, the corticotropin, which stimulates the production of glucocorticoids by the adrenal gland. Remember, there are three zones in the adrenal gland. There are three products that are common. There are glucocorticoids, predominantly cortisol. There are mineralocorticoids, predominantly aldosterone and androgens. They're made in, there's almost like three different glands here. If you look at it from kind of as you move inward, you kind of go from the area of mineralocorticoid production to glucocorticoid to sex steroids, and some people have kind of made the analogy, you're going from salt to sugar to sex, and it gets sweeter the deeper you go into the gland. Okay, so we'll leave it at that. So ACTH, though, regulates glucocorticoid production, and there's a feedback loop. But remember that aldosterone is not regulated by ACTH, it's regulated by the renin-angiotensin system and totally independent of this loop. And adrenal androgen production has its own program. It's really an enzymatic maturation of a series of enzymes that result in conversion of cortisol and aldosterone precursors into androgens. Remember, there's this phase just before puberty called adrenarche, but yet that's another stage, not regulated by ACTH, not regulated by renin. So we have to think about these as three separate processes, and they sometimes go together and sometimes not. So the most common form of adrenal insufficiency is primary adrenal insufficiency. There's a disruption in the adrenal gland itself. In the next slide, I will show you, just go through a list to kind of begin to think of how this can happen. But essentially what happens is you have end organ failure, you have of the entire gland, typically. It's rarely selective, so it's a failure of all three steroid productions, but as a consequence, you get diminished glucocorticoids, you get loss of feedback so that the ACTH production goes higher, tries to stimulate the gland, which is unresponsive. In response to the inability to produce aldosterone, you get upregulation of the renin-angiotensin system. So you have high levels of plasma renin or renin activity, angiotensin, and that loop is upregulated. So a consequence of this, now again, these are very separate, but they all make a clinical picture, like, as I mentioned, that can be complicated. In the absence of cortisol, you heard actually from Javier, it's a major counter-regulatory hormone for glucose. So when you have low cortisol, your body becomes very sensitive to insulin and other processes. Well, I'm still not, all right, I'm sorry. I don't mean to shout, but hypoglycemia is a very common consequence of glucocorticoid deficiency. Unrelated to that mechanism is the fact that your sensitivity to adrenergic agents is highly dependent on cortisol status, and when you reduce the cortisol, you lose vascular tone. You basically have circulatory collapse and shock. So those two things are quite different in their origins, but you get hypoglycemia, you get poor perfusion and shock. This is not an emergency, but it's part of the differential diagnosis of trying to establish who's got adrenal insufficiency. Cortisol basically inhibits the cross-linking of cartilage in structures like your ears and in your joints. But as a consequence of cortisol deficiency, you get increased cross-linking of cartilage and rigid structures like earlobes. I've yet to see this in all my years as an endocrinologist, but it's been well described that you can actually fracture an earlobe in someone who has primary adrenal insufficiency. Now, one other very important point to consider: when ACTH levels go up in effort to, as a response to the loss of feedback, you become hyperpigmented. Now, this is not a direct effect of ACTH. So there should be a little stopping point between ACTH and hyperpigmentation. Remember that ACTH is produced from a very large molecule in the hypothalamus called pro-opiomelanocortin, or POMC. But one of the other products of POMC, oops, let's go back here, is alpha MSH, melanocyte stimulating hormone. So when you have loss of this part of the axis and high ACTH, you tend to darken. I'll show you some pictures in just a moment. So why do you have primary adrenal insufficiency? By far, the most common in most Western cultures would be autoimmune destruction of the adrenal gland, Addison's disease. Now, Addison, when he described this in the 1800s, didn't know anything about autoimmunity. He was describing tuberculous adrenalitis. But so there are a number of funguses, HIV, tuberculosis is still common in parts of the world that can destroy the gland. Autoimmune system can do it. There are peroxisomal disorders. Probably the most common is X-linked adrenoleukodystrophy, which in some programs now is part of newborn screening. It's not unusual for newborns, and I don't really understand the mechanism, to have bilateral adrenal hemorrhages. I've run into this maybe 5 or 6 times in my career. Newborns who are born with adrenal hemorrhages, they're easily detected on ultrasound. They show up later as calcifications. You know that meningococcal infections can produce acute adrenal insufficiency with this Waterhouse-Friderichsen syndrome. There are other clotting disorders, the adrenal antiphospholipid syndrome, where you get clotting of the adrenal glands, but all of these result in damage to the adrenal gland. This is rarely seen in pediatrics, but there are some tumors that metastasize there. So these are causes of an intact adrenal being destroyed. There are several syndromes that involve transcription factors, DAX1 and steroidogenic factor 1, that result in absence of an adrenal gland, adrenal hypoplasia. There are rare receptor mutations in the ACTH receptor, the melanocortin receptor 2. So these are glands that don't develop properly. And then finally, there's this large category of defects where everything is intact except one or the other of especially these two enzymes, the 21-hydroxylase, the 11-hydroxylase, prevents the production of cortisol and aldosterone, and you get congenital adrenal hyperplasia. I will spend a little bit more time on that as we proceed. So that's primary adrenal insufficiency. Little less common, but definitely something to be considered, especially among pediatric specialists, is secondary adrenal insufficiency, where the problem is not here, the problem is there, with either the hypothalamus and the pituitary. There are some developmental disorders. Septo-optic dysplasia is a very common one that we see. Other forms of holoprosencephaly where the pituitary does not develop properly. There are tumors of this region, craniopharyngiomas, optic gliomas. If somebody goes to resect tumors there, you can have damage to the hypothalamus. It's particularly the hypothalamus, more so than the pituitary, is very sensitive to cranial irradiation. Trauma, you may not be aware of this, but in English, the common term is a whiplash injury with a motor vehicle accident. Where the head is snapped, you can easily sever the pituitary stalk and result in panhypopituitarism. It's not a rare injury. And I would be neglectful if I didn't mention another cause of secondary adrenal insufficiency. It's actually combined secondary and primary, is prolonged treatment with steroids. People that are chronically treated with steroids for asthma, for other autoimmune conditions, for steroids, often do not have the capacity to have normal dynamics of their ACTH glucocorticoid loop and can show signs of adrenal insufficiency. Again, they have no problems with this part of the axis. So now how is this different clinically than primary disease where you have damage of the adrenal glands? Again, you have low ACTH, you still have hypoglycemia, vascular collapse, but one of the more important features that distinguishes central adrenal insufficiency is you get a syndrome that's like inappropriate ADH release. In other words, you have water retention. And I'll show you in a table later, but that results in a dilutional hyponatremia. They often have low sodiums, but it's very different than the hyponatremia that you see when you have primary adrenal disease and you're not making aldosterone. In this instance, you have salt wasting, dehydration, and shock. Here you have hyperhydration, you're overwatered, you have low sodium, but you shouldn't confuse those two, because when you have primary disease and aldo deficiency, you treat aggressively with fluids. You can't treat this aggressively with fluids because you'll overload them. So you get the hypoglycemia, the vascular collapse, inappropriate ADH, and then water retention, this we talked about. You don't get the pigment changes. These are not people that are bronzed because ACTH and MSH don't go up. So just to contrast these two again, central and primary, the disorder is at the adrenal versus the hypothalamus or the pituitary. ACTH is low in central disease, it's high in primary adrenal insufficiency. Hyperpigmentation is part and parcel with primary disease. It's not seen in hyperpigmentation. Salt wasting, yes, it happens in primary adrenal disease. There are some forms of CAH that include, pretty routinely, I think you should think of congenital adrenal hyperplasia as including both mineralocorticoid and glucocorticoid, but deficiencies, but depending on the mutation, there are some people that still have a somewhat preserved mineralocorticoid axis. So you can get salt wasting or not, but you don't ever see salt wasting with central disease. And hyponatremia, though, is common to both. But again, be careful, because this is a form that you have to gingerly hydrate. This you can aggressively hydrate. Okay, so this is the part that I think is enlightening, but it's frightening. You can take all of these symptoms, and I'll go down through a couple of the ones I want to highlight in red, and this could be, you could parcel these together and convince yourself you're dealing with an infectious disease, a neurologic disease. That's why this disorder gets missed. It's really often chronic symptoms, so worsening fatigue, feeling bad, muscle weakness, no particular, it's not proximal or focal, but loss of appetite, weight loss, and nausea, to me, are very, very common things. It's almost like pregnancy. It's morning nausea that tends to be very typical of developing Addison's disease, often leading to vomiting. Diarrhea has been described. That's not something I'm used to seeing. But then here, hyperpigmentation, I'll show you that in a minute. I'll show you pictures. Postural hypotension. They get lightheaded. This is as they progress to really vascular collapse and shock. Hyperpigmentation, I'll show you photos, but tends to be in pressure points, particularly in scars and skin folds on the knuckles, often in the lips and mucous membranes. Salt craving, in the salt wasting forms of adrenal hyperplasia, those children, before you even make the diagnosis, if you get a good history, you'll find that the toddlers will take salt shakers from the table and pour it on their hands and lick it. People have a predilection to go for salty foods. In most Western cultures, if you like salty foods, you're going to get things like cheese, potato chips, things that carry a lot of fat with them as well, and often leads to obesity and hypoglycemia here. In girls, often you'll see irregular menses. But again, these symptoms, think of the ones in red. I think those are the classic ones, but you could see easily how you could be misled into thinking this is something not related to the adrenal gland and go down the wrong course. This is a pair of brothers that I saw a few years ago. I hope it's a little hard to see. They're country boys. They live outside. They play outside a lot. This is the boy. I hope you can see that his skin color is quite different from his brother. He had Addison's disease. A very astute pediatrician picked up on this and measured a serum cortisol and found it low with a high ACTH. The color is often not a natural kind of a tanning. It's not like people who've been out in the sun. Another very country family that I see from rural Alabama, the father described the color of his daughter to me as the color of a dirty penny. For those of you who know the American penny, the longer they come out kind of shiny, they're made of copper, but the older they get this kind of brown, orangey color. That's the color of Addison's disease. You can see it in buccal mucosa, gingival mucosa. You can see it here on the scars. And the reason I show you that earlobe is to think about playing with the ears a little bit. Just flap the ears. In Cushing's syndrome, where you have too much glucocorticoids, the ears get very floppy. Cross-linking is destroyed. Here, they're hyper-rigid. Don't try and break it, but that's another feature that you can pick up on. Laboratory studies. I think these should be pretty clear at this point. Hypoglycemia, hyponatremia, hyperkalemia with the aldosterone deficiency. I didn't mention that glucocorticoids suppress eosinophilia, and you often will see high levels of eosinophil counts. It should be on your differential diagnosis of someone with high eosinophil count would be Addison's disease. There's a hypercalcemia that has to do with clearance of calcium and a metabolic acidosis. So, adrenal hyperplasia, just to be quite brief, it's a autosomal recessive family of disorders. By far the most common is the 21-hydroxylase deficiency. Next would be the 11-hydroxylase. These are two enzymes that are required to put important hydroxy groups on cortisol and aldosterone. And let me just show you in the next slide where those molecules are. Here's hydrocortisone. There's the 21 carbon right there. So without that particular hydroxy group is on both aldo and hydrocortisone. There's the 11-hydroxylase there. The important point about why the viralization that happens in children with congenital adrenal hyperplasia is these two enzymes are totally irrelevant in the production of androgens. Androgen hormones cleave between the 17 and the 20 carbons there, so you have this 19, they're called C19 steroids because there's 19 carbons there, but there's nothing about the 11 or the 21 carbons. That one's not there and that one's not hydroxylated. So what happens is you have low cortisol levels, very high ACTH, so the ACTH is driving the gland to produce more cortisol, which it can't do because of this block in one of these two hormones, but it has no problem producing large amounts of androstenedione and DHEA, dehydroepiandrosterone. That's why these children virilize, in particular the little girls. I'll show you a picture in just a moment. But so the axis in CAH is you have a hyperplastic gland because it's being driven very hard by ACTH. You get hyperpigmentation because ACTH is high and MSH is high. You still can't make cortisol. You still have hypoglycemia. You have vascular collapse. You still have salt wasting, hypernatremia, hypokalemia, acidosis, and because you can't make that, but you have absolute, and your renin-angiotensin system is all revved up, but you have no problem making androgens. And what happens as a consequence of there's a normal adrenal, and here's a child with adrenal hyperplasia. I want to point out to you that a good ultrasonographer can actually detect this on ultrasound, and this is something you can do as a interim measure while you're waiting for confirmation of the diagnosis based on your laboratory test. 17-hydroxyprogesterone is the compound we measure for 21-hydroxylase, but often that'll take a few days and maybe even longer to get back. But you can get the sample, start treating the child, and an ultrasound might be quite helpful in saying these are massively hyperplastic adrenal glands. Here is a child, this is a female, a young girl who looks exactly like a cryptorchid male. This child, if you were able to lift up the phallus, has an absolutely normal penile urethra that empties at the tip of the penis. It can look exactly like a male. And that's why this is a child that's been a normal little girl, all the anatomy is intact inside, but who's been highly virilized to have a highly androgenized scrotum, clitoral enlargement to penis, and also closure of the urethral groove. And that's why another very important point for those of you who deal with infants is when you see a child like that, you should never assume the first thing on your differential should be CAH, not bilateral cryptorchidism. This happens, we all see this. There are boys that have empty scrotums, and in there you'll find, if you look hard enough, you can find testicles either in the inguinal canal or in the abdomen, but you should never assume that a newborn has that until you've ruled out congenital adrenal hyperplasia. The onset of CAH is usually not at birth. It's usually about 3 to somewhere in like 10 or 15 days. Hyperkalemia, hyponatremia, hypotension, we've been through this list. They have markedly elevated 17-hydroxyprogesterone. That's your diagnostic marker. In the 11-hydroxylase, which is a much smaller percentage of the kids, it's 11-deoxycortisol that's elevated. You have elevated renin levels or elevated plasma renin activity. And if you do an ultrasound, you'll see massively enlarged adrenals. When you treat an adrenal crisis, first thing is get the right samples. Just get at least a red top and a green top tube so you can measure these precursors, so you can measure renin. The marker of Addison's disease is antibodies against the adrenal, anti-21 hydroxylase antibodies. Those are detectable. But you get the proper sample, and then you treat aggressively in salt wasting with high dextrose, normal saline at least twice maintenance. You have to be careful, as I mentioned before. If you think it's because of a kid with brain tumor, brain irradiation, you don't use that level of water replacement. You treat them with 50 to 75 milligrams per square meter. If you're dealing with a newborn, in my simple mind, all newborns are 0.3 meters squared, so that's something like 50 milligrams a day of hydrocortisone. If you're using hydrocortisone at these high levels, you don't even need to worry about a mineralocorticoid in the initial resuscitation. In the chronic treatment, so somebody with Addison's disease, bilateral adrenal hemorrhage or CAH is treated with chronic doses of a glucocorticoid. I strongly prefer hydrocortisone. It's much easier to titrate. Some people use prednisolone or other prednisone, but I use hydrocortisone. You have to dose it at least 2 or sometimes 3 times a day. When they get older, I switch them to dexamethasone 1 time a day. Mineralocorticoid is with a drug called fludrocortisone. It's a 9-alpha fluorohydrocortisone. It's a very good but not totally effective mineralocorticoid. Babies often need much higher doses, 0.4 milligrams a day, 0.3, 0.2. Older kids are usually maintained well with 0.1 or 0.05. You monitor blood pressure, you monitor plasma renin activity to titrate this dose. Infants and older kids who play summertime sports, I'm imagining if you live in Amman in the summertime or in the desert, you often have to salt supplement. It's not a perfect mineralocorticoid. And to conclude about the management is you have to remember that these children are unable to increase their hydrocortisone production when you induce anesthesia, when there's major trauma, when they get sick, when they have fever. So you have to go from a maintenance dose, which is somewhere around 15 to 20 milligrams per square meter per day, to 50 milligrams per square meter per day. All of our children have a prescription at home for an injectable form of hydrocortisone for emergencies. This is the trade name in the US is Salucortef. There are other versions of this available to give intramuscularly before they head for the hospital. That's not considered a treatment. It's an interim step. If the kid is suddenly deteriorating quickly at home, they call an ambulance, they give an injection of Salucortef. It could be 100 milligrams of Salucortef. I ask all my children with this to get to wear IDs. We've actually produced our own to give out to our families. This is a young man, a patient of mine, who wanted a nice tattoo. That's a very big tattoo, but it says he's got adrenal insufficiency. You can't miss it. I strongly urge, this is a population that should get flu shots every year. Every year, children die who have adrenal insufficiency who contract influenza.
2 minutes, please.
Okay, just one last point here. The context of Addison's, it's autoimmune. This is a list of other autoimmune diseases. You'll recognize many of these. They're not rare. Type 1 diabetes, Hashimoto's thyroiditis, Graves' disease, any one of these. If you have a child who begins to develop some of the symptoms we're talking about, the nausea, the weight loss, and they have any other autoimmune disease, the first thing on your list should be to think about Addison's. They run in the same families. One last point is that there's a very important interplay between the thyroid axis and the adrenal axis that everybody should be aware of. If you are hypothyroid, it reduces your clearance of cortisol. In other words, your cortisol lingers longer in the hypothyroid state, so that hypothyroidism can mask the clinical manifestations of adrenal insufficiency as it's first developing. So if you treat somebody for their hypothyroidism, it'll increase the clearance of cortisol. So let me just show you one case and then we'll stop. A 13-year-old boy that came to our hospital had type 1 diabetes, diagnosed at age 9. He complained of fatigue and nausea. He went to a local emergency room, so fatigue and nausea. They gave him fluids. He felt better. He was sent to our hospital. He was evaluated and found to have a somewhat elevated TSH, a normal free T4, and actually they documented he had positive antithyroid antibodies. This fits together, type 1 diabetes, Hashimoto's thyroiditis. But the thinking stopped there. He didn't have a goiter. He was started on levothyroxine. A month later, he woke at home with altered mental status, a low blood glucose in the doctor's office. Mother had been checking, this is a kid with diabetes, nocturnal hypoglycemia. And then 2 weeks after that, he presented with vomiting, poor appetite, low blood sugars, and confusion. And his sodium was low, his glucose was okay, eosinophil count was somewhat elevated, cortisol unmeasurable, ACTH 1600, normal's up to 50, and positive antibodies. So he has type 1 diabetes, Hashimoto's thyroiditis, and he almost died of unrecognized Addison's disease. That's the context I want you to think about. This is the case where treating his Hashimoto's precipitated the adrenal crisis. And I will stop there. I will leave this for you to look at. If this hasn't reached them on yet, this is the latest scourge of the popular press now is adrenal fatigue. I never heard about it in medical school, but if you haven't yet, you're going to have patients coming to you. People write articles, people sell things like loss of a loved one, fear, trauma, unwanted unemployment. These are the causes of adrenal fatigue. If you haven't heard about it in medical school, there's even a book, Adrenal Fatigue for Dummies. Not that applies to anyone in this room, but don't look for me for advice about this. It's in the popular press. Thank you.